Welcome to this presentation on the Clinical Atlas of Reproductive Gynecology. Today, we will explore the anatomy, physiology, and common pathologies encountered across the female reproductive life YCLE. We begin with the uterus, divided into the fundus, body, and cervix. Note the standard uterus-cervix ratio, which shifts from 1:1 at puberty to 2:1 in adults. The adnexa includes the fallopian tubes, comprising the intramural, isthmus, ampulla, and infundibulum, and the ovaries. A key clinical pearl: a short cervix, less than 2.5 centimeters, carries a significant risk for preterm labor. The follicular attrition curve shows a peak of 6 to 7 million follicles at the 20th intrauterine week, dropping to 1 to 2 million at birth and roughly 300,000 to 400,000 by puberty. Maturation progresses from primordial follicles to the dominant pre-ovulatory follicle. For assessment, serum AMH is the single best test for ovarian reserve. A level under 1 nanogram per milliliter suggests poor reserve. The hypothalamic pituitary ovarian (HPO) axis regulates the cycle. GnRH from the hypothalamus stimulates the pituitary to release FSH and LH, which in turn signal the ovaries to produce estrogen and progesterone. The cycle is divided into the follicular/proliferative phase, where estrogen thickens the lining, and the luteal/secretory phase, where the corpus luteum produces progesterone to stabilize that lining. Puberty is triggered by the maturation of the HPO axis, with approximately 17% body fat required for menarche. The sequence typically begins with the growth spurt, followed by the lark, breast development, pubarch, hair growth, and finally menarche. We use Tanner staging to track these developments. Clinical anomalies include precocious puberty before age 8. Polycystic ovary syndrome is diagnosed using the Rotterdam criteria, requiring 2 of 3 pillars: oligo, anovulation, hyperandrogenism, clinical or biochemical, and polycystic ovarian morphology. On ultrasound, a polycystic ovary often displays a classic ring of pearls distribution of follicles. The trigger for PCOS is an increased GnRH pulse frequency, leading to an elevated LH-FSH ratio, greater than 3:1. This causes an ovarian cascade of hyperandrogenism and follicular arrest, and a systemic cascade involving insulin resistance and high fasting insulin. These factors often target metabolic syndrome markers, such as increased waist circumference and elevated blood pressure. This matrix compares 3 major conditions: endometriosis, tissue outside the uterus; adenomyosis, glands infiltrating the myometrium; and fibroids, smooth muscle tumors. Key symptoms range from severe dysmenorrhea in endometriosis to heavy bleeding and asymmetric enlargement in fibroids. Sampson's implantation theory suggests retrograde flow of tissue through the fallopian tubes. Pathological hallmarks include powder burn lesions, chocolate cysts, endometriomas, and "kissing ovaries" due to adhesions. Severity is staged from I, minimal, to IV severe, based on ASRM classification. Adenomyosis involves the disruption of the endometrial-myometrial junctional zone, causing symmetric uterine enlargement. Unlike fibroids, which have a distinct pseudocapsule, adenomyosis presents with strictly diffuse borders and lakes of blood trapped in the muscle. Uterine fibroids, leiomyomas, are classified by location using the FIGO system, ranging from type 0, pedunculated intracavitary, to type 8, parasitic/cervical. Histologically, they consist of spindle-shaped cells and characteristic whorls of smooth muscle. Menopause, occurring at an average age of 52, is defined by dropping AMH and rising FSH. The loss of estrogen has systemic effects: vasomotor symptoms in the brain, hot flushes, osteoporosis in the bones, loss of protective lipid profiles in the heart, and vaginal atrophy in the pelvis. Prolapse occurs when the levator ani and pelvic ligaments, like the McEnroe, fail, often due to a combination of estrogen loss and childbirth trauma. Variants include cystocele, bladder, rectocele, rectum, enterocele, small intestine, and uterine prolapse. HRT is indicated for hot flushes, severe osteoporosis, and vaginal atrophy. However, it is absolutely contraindicated for patients with active liver disease, history of breast cancer, or undiagnosed vaginal bleeding. A vital clinical pearl: if a patient has a uterus, progesterone must be added to estrogen therapy to prevent endometrial cancer.